Female reproductive pathology, a good topic, not too hard, not too easy, but some of the things could be a bit confusing. This I made mostly from the book. What is not from the book has its resource linked below. I think it's very important for you to use official resources, namely your professors and teachers. Please do not disregard the lectures. They are very, very useful. Nonneoplastic and premalignant lesions of the uterine cervix. Anatomy and terminology. Please take a moment and read through the slide. Then we will discuss the squamocolumnar junction, the squamous metaplasia, and the transformation zone. The picture on the left shows us the endocervix and the ectocervix and how they divide the upper and the lower female reproductive tracts. The endocervix is covered by the simple columnar epithelium that we also call the glandular epithelium. The ectocervix is covered by the stratified squamous epithelium. Why? Because we need the secretory properties of the simple columnar epithelium in the upper reproductive tract, and we need the protectory qualities of stratified squamous epithelium in the ectocervix and in the vagina. What for? Two major things: mechanical damage from intercourse and the acidic pH of the lactobacillus, which is good for us because it prevents foreign microbes from colonizing the area. And then if you're pregnant or you're taking antibiotics, etc., that could harm the balance of lactobacillus, and then pH could increase, and then we lose this protection against foreign microbes, and we are more easily susceptible to yeast infections, for example. And of course, other infections too. The external os is the anatomical area where the ecto and endocervix meet. But it's not where the squamocolumnar joint necessarily is, because the squamocolumnar junction moves with age and with hormonal balancing changes. And in fact, mostly it moves from the ectocervix towards the endocervix until late in life. It's so inside the endocervix that we cannot see it anymore. So here are bullet points for the transformation itself across the different ages. In prepubertal women, the original squamocolumnar junction is found near the external cervical os in the ectocervix. And then after puberty, during the reproductive years, under influence of estrogen, we have not just changing of the epithelium itself, but also the organs themselves, like the vagina and the uterus. They swell, they grow, they enlarge, and then there is basically anatomical movement of these areas, and there is a version of the lower endocervix and its glandular epithelium outwards, and now it's further on in the ectocervix, further away from where the cervical os is. Okay. 4. The acidic vaginal environment, which is under 4.5, leads to the destruction and replacement of this averted columnar epithelium. Now, when the columnar epithelium is so far away from the cervical os and it's not protected anatomically anymore from the pH, we have it receiving damage from the pH, and then we have a reactive process, which we call squamous metaplasia, because the stratified squamous epithelium is more resistant to the pH. 5. The metaplastic process starts at the original squamocolumnar junction, moving centrally towards the external os. What that means is that there is growth of stratified squamous epithelium from where the original squamocolumnar junction is towards the cervical os. 6. The new squamocolumnar junction is formed between the metaplastic squamous epithelium and the glandular epithelium. Basically, now the new squamocolumnar junction is where the squamocolumnar junction moved to. And the area between the new and the original is called the transformation zone. And the transformation that occurs within it is the squamous metaplasia. 7. Perimenopausally and afterwards, postmenopausally, the atrophic cervix shrinks and it moves this new cervical junction into the endocervix, and then it's no longer visible anymore. Nice picture. Here's a few points on the lactobacillus maintaining a protectory environment using lower pH and production of hydrogen peroxide to prevent other pathogens from colonizing the external reproductive tract. Cervicitis, inflammation of cervix, acute or chronic. The most important risk factors are sexual activity, like having sex with more people and having it unprotected, because you expose yourself to more pathogens this way. The infectious etiologies are Neisseria, gonorrhea, and Chlamydia trachomatis. Those two are by far the most common, but somewhat less commonly, HSV, herpes simplex virus, Trichomonas vaginalis, and Mycoplasma genitalium. Non-infectious etiologies are mechanical, like mechanical trauma, for example, with surgical instruments, with condoms, with diaphragms, with cervical caps or tampons, and chemical irritants, like soaps, laundry products, spermaticides, latex, vaginal douches, and contraceptive creams. The clinical picture is purulent or mucopurulent vaginal discharge, intermenstrual or post-coital bleeding, dyspareunia, meaning pain during intercourse, potentially associated with urinary symptoms, because you can get also a UTI while you're having it, or it can spread to the urethra, or abdominal pain in case the infection rises up, ascends through the female reproductive tract to the endometrium, causing endometritis, to the fallopian tubes, causing salpingitis, to other pelvic organs, causing pelvic inflammatory disease. Screening and its importance. Cervical carcinoma worldwide is the third most common cancer in women and the 13th in cancer mortality, but only 50 years ago it was number 1. Why has that changed? Not just screening, but screening played a big part of it. So, we do a pap smear, pap test, to detect the precursor lesions to cervical carcinoma. When we find them early enough, we can get rid of them and prevent it. Sometimes we don't find it early enough for them to not turn into carcinoma, but we can find them as early stages of carcinoma and prevent them from, example, spreading. So the early prophylaxis or the early treatment saves lives. The accessibility of the cervix to pap testing and visual exam, also called colposcopy, as well as the slow progression from precursor lesions to invasive carcinoma, years, provides ample time for screening, detection, and preventative treatment. High-risk HPVs are by far the most important factor in the development of cervical cancer. There are about 15 high-risk HPVs currently identified, but HPV 16 accounts for almost 60% of cervical cancer cases and HPV 18 for another 10%. High-risk HPVs are also implicated in SCC arising at many other sites, including vagina, vulva, penis, anus, tonsils, and oropharynx. HPV carcinogenic activity is via hijacking the cellular mechanisms to produce its own proteins. Two of these proteins are the oncogenetic proteins E6 and E7, which interfere with tumor suppressor proteins that regulate cell growth and survival. Genital HPV infections are extremely common and most are asymptomatic, lack tissue changes, and are thus not detected on pap smears. The peak prevalence of these early asymptomatic cases is between the ages of 20 and 24 due to the onset of sexual activity. Most HPV infections are transient and are eliminated by the immune response within a few months. 50% are cleared within 8 months, 90% within 24 months. But persistent infections increases the risk of development of cervical precursor lesions as subsequent carcinoma. HPV infect immature basal cells of the squamous epithelium in areas where they are exposed. So either you have epithelial breaks or in the transformation zones where the immature metaplastic squamous cell transformation allows them to infect the immature basal cells. This is why the cervical cancer is so much more common in the transformation zone. It's a very important fact. Lastly, HPV vaccination saves lives. We give it to pretty much any girl around the age of 12, 13, 14, because it gives something like 15 years of anti-HPV activity before kind of immunogenicity lays down. So you can take it again now or when you're nearing your 30s, and it should prolong it by another 15 years as a booster shot. But the most important time is to cover the onset of sexual activity and the most sexual active time in a person's life. Premalignant lesions, just like last time, it's the intraepithelial neoplasia. Here it's cervical, so CIN, and the squamous intraepithelial lesions divided into L-seal and H-seal. Of course, beforehand, decades ago, there was just mild dysplasia, moderate and severe, and carcinoma in situ. And then the cervical intraepithelial neoplasia classification, SIN1, meaning that the thickness of epithelium has less than 1/3 of it dysplastic. SIN2 means that less than 66% of the thickness of the epithelium is dysplastic. And SIN3 is under 99, 100 is carcinoma in situ, over 100 is invasive carcinoma. Keep in mind that the less the dysplasia thickness is, the more of a chance there is for regression. So meaning that like the body can win against the dysplastic cells, get rid of them, and nothing bad happens in the end. Everybody's happy. But the patient management is two-tiered: observation and surgery. That's the most important part about cervical carcinoma treatment. So instead of talking about SIN 1, 2, and 3, we talk about L-seal and H-seal, because L-seal is with far better prognosis than H-seal, which requires much more radical therapy. Upon covering the entire epithelial thickness, carcinoma in situ, then invasive carcinoma. Okay, L-seal and H-seal, a few more words, very important to remember, that in VIN, in volvular intraepithelial neoplasia, we talked about UVIN and DIVIN, we talked about L-seal and H-seal there. And if you remember, L-seal there is associated with the HPV, and H-seal there is not associated with HPV. But here, this is not the case. Both cervical L-seal and H-seals are associated with HPV. But what the cell is undergoing due to the HPV is different, and there is more of a linear progression here. In L-seal, the HPV is in phase of active viral infection. It infects cells, it replicates within them quickly, and it spreads quickly. Therefore, we have less dysplastic cells, but we have more infected cells overall. In H-seal, there are less infected or less newly infected cells, less perhaps of some acute inflammation, but the cells that are currently already infected are undergoing deep changes due to the presence of many viral proteins. Some of them are those E6 and E7 proteins, which promoted oncogenesis within the cell, turning it dysplastic with time. For the same reason, there is a chance that L-seal would regress that H-seal doesn't have, and therefore you don't have to surgically remove L-seal from the cervix. How do we diagnose SIL? Using a pap smear, right? What do we look for? We look for choleliocytosis and its markers, because it's almost always associated with HPV in the cervix. SIL grading. So this is exactly what we discussed earlier about the thickness of dysplastic cells within the epithelium or within the epidermis. So the grading of SIL into L-seal and H-seal is based on the expansion of the immature cell layer from its normal basal location, meaning it spreads upwards. If the immature squamous cells are confined to the lower 1/3, it's L-seal or SIN1. If they expand to the upper 2/3 of thickness, it's H-seal. But remember, under 66%, it's SIN1, and between 99 and 66, it is CIN3, 100 carcinoma in situ, then it invades, becoming invasive carcinoma. Cervical adenocarcinoma in situ, AIS. Adenocarcinoma signifies its glandular epithelial origin. The in situ part signifies that it's a precursor lesion to invasive adenocarcinoma. This one is mainly associated with high-risk HPV, particularly the cervivar 18. The common location is either in the transformation zone or in the endocervix. The typical patient is a reproductive age woman, let's say around 29 years old. Clinical picture is typically asymptomatic but could be rarely abnormal vaginal bleeding. Diagnosis is via colposcopy with a biopsy of the visible lesion and endocervical curettage to remove it. Microscopy shows dysplastic changes, atypical glandular cells in strips and sheets with prominent nuclear crowding. The biopsy proving AIS should be followed by cold knife conization to evaluate the extent of AIS and exclude invasive adenocarcinoma already. If fertility is not an issue, hysterectomy, so complete removal of the uterus and the cervix, is the preferred treatment. SIMLE, stratified mucin producing intraepithelial lesion. It is a rare high-grade cervical precancerous lesion designated a variant, a subtype of adenocarcinoma in situ by the World Health Organization. Microscopy shows architectural features of cellular stratifications like squamous intraepithelial lesions, crowding, pronounced increased nuclear cytoplasmic ratio, hyperchromasia, mitosis, and apoptosis, plus some cells shows cytoplasmic mucin vacuoles. Essentially, it is a subtype of adenocarcinoma that shows some microscopic characteristics of adenocarcinoma in situ and some of squamous intraepithelial lesion. Thank you for listening. Hope this video was helpful. See you next time.